Hello viewers, my name is Dr. Rajiv. Welcome to my education channel YouTube Surgery and Orthopedic Education. Please consider subscribing it as well as share it to your near and dears to help them in their preparation of MBBS course as well as postgraduate entrance examinations. Also, don't forget to press the bell icon below so that you never miss an update from us. Today's discussion is about a chronic, progressively destructive infectious disease of the subcutaneous tissues that spreads to affect the skin, deep tissues and bone known as mycetoma or madurafoot. Mycetoma is a chronic, granulomatous, progressive and destructive infection of the skin, subcutaneous tissues and deeper structures. It is caused by a bacteria, actinomycetes, known as bacterial mycetoma or actinomycetoma, and by a true fungi, Eumycetoma, known as fungal mycetoma. But the clinical features are quite similar in both types. Bacterial mycetoma is common in South and Central America, whereas fungal mycetoma is usually seen in Asia and Africa. Mycetoma typically presents as a triad of painless subcutaneous mass, multiple sinuses, and seropurulent discharge containing white, yellow, red, brown, or black sand-like particles called grains. Lesions typically affect the lower extremities, but it can involve any region of the body. It usually occurs in farm workers and nomads. The disease can progress to large bone invasive mutilating lesions with tissue destruction, deformity, disability and death in extreme cases. Mycetoma was first reported in Madurai district of India in 1842 and hence it is also called madurafoot. Later it was named as mycetoma due to its fungal etiology. Bacterial mycetoma due to actinomycetes should not be confused with actinomycosis, which is caused by Actinomyces israeli. Actinomycosis typically affects cervicofacial, thoracic and pelvic regions. Mycetoma occurs in equatorial regions of Asia, Africa and Latin America known as the Mycetoma belt, comprising the countries of India, Venezuela, Colombia, Argentina, Sudan, Somalia, Senegal, Yemen, Mexico and a few others. Actinomycotic mycetoma is caused by a species of actinomycetes such as Nocardia braziliensis, Streptomyces somaliensis, Actinomadura maduri and Actinomadura pelletieri. Most eumycotic mycetoma is caused by Madurella mycetomatis. The different species produce grains of different colors. Mycetoma organisms enter through sites of penetrating local trauma on the feet or on the extremities or back of workers carrying contaminated vegetation. Mycetoma occurs most often in farmers, shepherds and nomads of 20 to 40 years of age. The foot is the most commonly affected site. Mycetoma is not contagious. A granuloma forms at the site of entry which increases in size and the overlying skin becomes stressed, smooth, shiny and tethered to the lesion. Areas of hypo or hyperpigmentation may also develop. If neglected and untreated, the lesion invades the deeper structures. Deep invasion is usually gradual and delayed in eumycetoma, whereas this occurs earlier, deeper and is more extensive in actinomycetoma. The tendons, nerves and blood vessels are involved very late. That is why neurological and trophic changes are rare even in patients with long-standing disease. Local spread occurs along tissue planes. Lymphatic spread occurs and is more common in actinomycetoma. Hematogenous spread can also occur. Mycetoma is a painless condition, hence the patient becomes aware of the disease late. It presents as a slowly growing, painless, subcutaneous swelling at the site of trauma. The disease begins as a small herb nodule that can persist for long or may evolve to form extensive lesions of more than 20 centimeters in diameter. Eumycetoma remains more localized and progresses slower than actinomycetoma. The swelling may be firm and round, soft and lobulated, and is often mobile. Rarely it may be cystic. Lesions may suppurate and drain through multiple sinus tracts. They discharge serous, serosanguinous or purulent fluid. The sinuses discharge grains during the active phase. The color of grains can be black, yellow, white or red depending upon the species of the organism. Old and new sinuses may coexist, while some of the older ones may heal completely. They may coalesce to form abscesses. Lesions may become painful if there is secondary bacterial infection. The common sites affected are foot in 70% and hand in 12% of cases. In endemic areas, the lesions may involve knee, arm, leg, head, neck, thigh and perineum. Sometimes there may be areas of local hyperhidrosis over the lesion. This may be due to sympathetic overactivity or raised local temperature due to increased blood flow from chronic inflammation. Lymphadenopathy is common, and in most of the patients, the regional lymph nodes are small and hard. Constitutional symptoms like fever or pain are a sign of secondary bacterial infection. The extent and spread of the disease cannot be reliably predicted by clinical examination. Therefore, local anesthesia is contraindicated in mycetoma surgery. Cachexia and anemia may develop in late cases due to malnutrition and sepsis. Mycetoma should be distinguished from chronic osteomyelitis, actinomycosis, tuberculosis, primary osteogenic sarcoma, Kaposit sarcoma, malignant melanoma, fibroma, bone cysts, syphilitic osteitis, and foreign body granuloma. In endemic areas, a high index of suspicion should be maintained, and any subcutaneous nodular swelling must be considered a mycetoma until proven otherwise. Imaging techniques available to reach the diagnosis are X-ray, ultrasound, CT scan, and magnetic resonance imaging. In the early stages, soft tissue shadows are apparent on X-ray with calcification and obliteration of the facial planes. When bone is involved, the cortex is compressed from the outside by the granuloma, leading to cortical thinning and bone scalloping. Further on, periosteal reaction may result in new bone formation presenting as sun reappearance and may create a Codman triangle like that seen in an osteogenic sarcoma case. Later, multiple punched out cavities throughout the bone may also be seen. Ultrasound helps differentiate mycetoma from non-mycetoma conditions as well as between eumycetoma and actinomycetoma. In mycetoma lesions, ultrasound shows thick walled cavities with hyperreflective echoes and no acoustic enhancement. On the other hand, in non-mycetoma lesions, there are no such findings on ultrasound. In eumycetoma, the grains produce sharp, bright, hyperreflective echoes. In actinomycetoma, the hyperreflective echoes are fine and less distinct and commonly settle at the bottom of the cavity. Ultrasound also helps in planning surgical treatment as the size and extent of lesions can be accurately determined by ultrasound. Magnetic resonance imaging helps in assessment of the extent of the soft tissue and bony involvement. The dot in circle sign, which indicates the presence of grains, is a highly characteristic MRI sign of mycetoma. CT findings in mycetoma are not specific but provide better details of changes than plain radiography. The grains obtained from open sinuses, fine needle aspiration, punch biopsy, or surgical excisional biopsy are first microscopically examined. When microscopic examination fails to reveal fungal or bacterial elements in discharged grains, deeper tissues are needed for testing. The deeper tissues can be obtained through punch biopsy, deep surgical biopsy, and fine needle aspiration. Surgical biopsy samples obtained under general or regional anesthesia contain grains and should be fixed immediately in 10% formal saline. Three types of host tissue reactions are identified. In type 1, the grains are surrounded by a layer of neutrophils. Outside the zone of neutrophils, there is granulation tissue. The outermost zone consists of fibrous tissue. In type 2, most of the neutrophils are replaced by macrophages, plasma cells, lymphocytes, and multinucleated giant cells. In type 3, there is formation of epithelioid granulomas containing Langerhans germ cells and a scattered fungal material. These three types of histological manifestations are not separate events but reflect the different stages of the pathogenesis from acute to chronic infection. Fungal or bacterial pure cultures of grains obtained through deep surgical biopsy can identify the causative microorganisms based on the colony's morphological and biological characteristics. In the absence of the classical clinical features, the common serological tests to diagnose mycetoma are immunoelectrophoresis and ELISA. The treatment of mycetoma should be a combined effort of a physician and a surgeon. Antibacterial or antifungal therapy should be used first and surgery may be combined as needed. Medical therapy often lasts for months to years. Medical therapy alone may be sufficient for actinomycetoma, but surgery is usually needed for Eumycetoma. Trimethoprim sulfamethoxazole or co-trimoxazole is the drug of choice for actinomycetoma. In actinomycetoma, combined drug therapy with amikacin and co-trimoxazole in the form of 5-week cycles is the treatment of choice. Second-line drugs are amoxicillin clavulanic acid, rifampicin, sulfonamides, gentamicin, and kanamycin. Most effective drugs in Eumycetoma are ketoconazole, itraconazole, and voriconazole. In Eumycetoma, medical therapy is not curative. Drugs only help to localize the disease to make it suitable for surgical excision. Treatment of Eumycetoma is generally more prolonged and less successful than for actinomycetoma. In mycetoma, the indication for surgery is a small localized lesion resistant to medical treatment. The surgical options are wide local excision and amputation. Amputation is indicated in advanced disease with severe secondary bacterial infection refractory to medical treatment. Medical treatment should continue sufficiently long in post-operative period to prevent relapse.